Hello everyone, my name is Terry King. I'm a clinical informatics pharmacist at East Tennessee Children's Hospital in Knoxville, Tennessee. I want to provide you a brief overview of my presentation, Pharmacologic Management of Infants with NAS. I will remind you that the full slides and bibliography is available for download online, so you have access to that. Thank you for watching. I do not have any conflicts of interest to disclose. So I'll get right in to our goals of NAS treatment. We want to ameliorate the withdrawal symptoms that the baby is experiencing so that the infant can achieve adequate sleep and nutrition that will enable normal and weight gain and social integration with the mother and father and others. This will also, we want to be sure to achieve this effect with the fewest number of medications on board at the lowest dose for the shortest duration. We think that is the best benefit for the baby. So the choices we have in the opioids are drugs that you're already familiar with: morphine, methadone, and buprenorphine. Morphine, being the shortest half-life of the three, may offer some advantages to be able to make dosing changes and tapers more quickly, but all three are very effective, and the Cochrane review and the AAP guidelines recommend that for opioid withdrawal, that opioids should be first-line treatment. Another choice that we have before us is weight-based versus symptom-based. The weight-based strategy uses an initial dose of 400 micrograms per kilogram per day divided every 4 hours. Comes out to about 70 micrograms per kilogram per dose. And this is the strategy that many are familiar with in our NICUs as we dose all of our drugs, essentially using a weight-based strategy. An alternative is using a symptom-based treatment strategy where the initial dose is adjusted according to the baby's symptoms. The more severe the baby's symptoms, the higher the dose, and you can see the charts on the slide before you. One advantage that the symptom-based, I believe, has over the weight-based is that you have potentially lower doses to begin with, which would achieve our goal of using the lowest dose for the shortest time. For example, in our institution, we've treated about 1,500 babies, and the most common starting dose is 40 micrograms. As many of the babies are 3 or 3.5 kilograms in weight, that would be compared to a weight-based initial dose of about 200. One of the adjuncts that's available for add-on treatment is clonidine. It's an alpha-2 agonist drug, and it helps to ameliorate the adrenergic symptoms of withdrawal, the norepinephrine portion that has things to do with the restlessness and the tension, the fast breathing and the like in that. So it acts somewhat as a sedative. It ameliorates the norepinephrine. Another add-on is phenobarbital, and it is the sedative of choice for opioid withdrawal according to the current Cochrane review. However, it is falling out of favor somewhat because of the potential to have neuronal apoptosis and some adverse neurodevelopmental effects. So it is seeming to be used less, but it's still effective. The most important and the most perhaps effective strategy that we could have to treat these infants is the use of a standard treatment protocol. That doesn't mean that everyone does the same thing throughout the country, but it means within an institution, if you have a standard treatment protocol that your providers adhere to, that seems to have benefit for reducing length of stay and the length of taper. And so I would recommend that to you. And that's the summary. Thanks for watching. If you have questions, you can contact me at the email before you, and have a great day.